Hello, the distinguished moderator and the organizer of the World Congress of Anesthesia, and all the colleagues online. It's such a great honor to me to meet you here in this way. It's also a great honor for me to share this topic, how to minimize the opioid use in ambulatory anesthesia. I am Dr. Le Shen from the Department of Anesthesiology, Peking Union Medical College Hospital. I'm now the professor and the deputy chair of the department. It's also my great honor to be here to share this topic on behalf of China's anesthesiologists and also on behalf of Chinese Society of Anesthesiology. I'm from the hospital, Peking Union Medical College Hospital, PUMC Hospital, which was founded in the year 1921 by the Rockefeller Foundation. And coming September 16th is the 100-year anniversary of the hospital. Our hospital is always the top one hospital from the year 2009 till now, and also it's very proud of me. I graduated from the medical school, the PUMC Peking Union Medical College, in the year 2008, and get both medical doctor degree, and PhD. I'm now the committee member and vice general secretary of Chinese Society of Anesthesiology. For this topic, how to minimize the opioid use in ambulatory anesthesia, which also means we should plan our anesthesia or plan the ambulatory cases with opioid-sparing anesthesia. For this consideration, we should make our clinical plans from three aspects that closely related to the ambulatory cases: the pain severity, and the type of surgery, and also the patient's condition. Anyway, we should make sure to provide ambulatory patients better pain control and faster recovery. Different types of surgery lead to different pain features and severity. Opioids can reduce the pain sensation, but not the pain origins. Obviously, opioids can cause several adverse events such as constipation, slowed breathing, nausea and vomiting. Some long-term effects like addiction and immune suppression should also be considered. Since the concept of ERAs were raised by Dr. Kellett in 1990s, multimodal analgesia has become one of the most important parts in almost all ERAs protocols. We can use different drugs from peripheral to the central and focus on different pain mechanisms. The regional block is very popular and effective in opioid-sparing ambulatory anesthesia, especially for some superficial nerve block. They are also very safe for day surgeries patients. The thoracic epidural can cover many types of surgeries, and the thoracic epidural is also beneficial for reducing pulmonary complications, improving valve function, reducing cardiovascular morbidities. However, for ambulatory patients, a thoracic epidural may not be the first choice, because we should not discharge the patients without removal of the epidural catheter. Intravenously, infusion of lidocaine is very safe and effective for most ambulatory cases. We tried we tried a multimodal analgesia protocol with lower dose lidocaine 1 mg per kilogram per hour, as most guidelines of ERAS recommended 2 to 3. The results showed that lower dose of lidocaine is also well enough for gynecological ambulatory laparoscopic cases. The paracetamol may be well known for its opioid-sparing effects. It's very safe, even with a maximal daily dose of 4 grams. And NSAIDs and COX-2 inhibitors are also very popular stars in multimodal analgesia for ambulatory patients. Besides, they may also inhibit the tumor cell proliferation. But up to now, all these results are mostly from the basic research. Although in recent years, perioperative abusing of gabapentinoid has become a new problem. For those surgeries that may cause significant nerve injuries such as thoracoscopy, mastectomy, and so on, either gabapentin or pregabalin still need to be considered for the prevention of chronic post-operative pain. Ketamine, or the recent esketamine, can facilitate the ambulatory anesthesia through the inhibition of NMDA receptor. Our recent findings show that ketamine can also relieve the itch or pruritus sensation that caused by the opioids, especially caused by the epidural morphine. In our study, we found that either ketamine, a non-selective NMDA receptor antagonist, or a selective NR2B antagonist, efemprogil, can improve the analgesic effect of epidural morphine and reduce the itch sensation that caused by the epidural morphine. For dexmedetomidine, a single dose may be well enough for ambulatory anesthesia, with or without the followed infusion. The single dose dexmedetomidine, 0.5 to 1 microgram per kilogram in 15 to 20 minutes, has been tested effectively for reducing post-operative pain control and reducing post-operative nausea and vomiting. Another very interesting and also maybe safe and maybe effective drug is vitamin C. The vitamin C is a free radical scavenger that can do a lot of things. For the pain control, the vitamin C is effective for the pain control of complex regional pain syndrome. Our results show that vitamin C can enhance the analgesic effect of gabapentin through some different mechanisms. So maybe vitamin C can also reduce the adverse effect of gabapentin through reducing the dosage or decrease the dosage of gabapentin. So, for the opioid-sparing ambulatory anesthesia, several non-opioid drugs and techniques are available now. This is our recommended protocol for the Euro-ambulatory anesthesia cases, and we hope it also works in your practice. And finally, thank you again for the attention on our lecture, and we hope we can have more discussion and communication in our future, academic meetings or conferences. Thank you again. See you.